Hello and good morning, or good afternoon, or good evening, or whatever time you're watching this. But where I am, it is morning. I am so glad to bring you this chat with Carl Monaghan this morning. It's something I've been wanting to do for quite a while. Carl and I met online a couple of years ago, and we've chatted a lot about our approaches to pelvic pain and pelvic health, specifically with men. And he's a bit of a visionary. He's a really, really genuinely wonderful man, which you'll see from this film. But he's very, his work is evidence-based, and he's really good at drawing in the evidence and drawing in the research that we have, and forming a really holistic, a truly holistic in the most evidence-based sense of the word, vision of how we can serve men better. And he's doing that in everything he does. So Carl works from the Pelvic Pain Clinic in Islington in London, and I'll put a couple of links to how you can get hold of Carl below this video. He also, so he treats men with pelvic pain, chronic prostatitis, chronic complex pain, any kind of pain that you want to talk about in men, Carl treats, and occasionally a woman, but mostly men. He runs a fantastic support group as well online where men can get together and there are experts in situ, and you can have really good open conversations to support each other about your pelvic pain. So if that's something that you're interested in, or you feel that you need to be able to talk to someone, an online space is just incredibly friendly and supportive and evidence-based and helpful. Because often it's really hard to talk about these things. So we don't talk about male pelvic pain enough. Men have pelvises. They get pain as well, and it is something that we can treat and we can change. Men can get better from pelvic pain, but you have to be able to talk about it first, and knowing that there's other people out there going through the same thing and that there is treatment available can be really helpful. So this one is for therapists, for physios, for all kinds of therapists that are treating male pelvic pain, but it's also for patients. Remember, this isn't an adjunct for medical advice. You need to go and see your doctor, and that's where your conversation should start if you've had any pain at all. It doesn't necessarily mean it's prostate cancer. A lot of people are terrified that it's prostate cancer. Just go see your GP, start that conversation, have the test done, and when the tests are done, go see someone that can help you. And often getting in touch with Carl or having a search online for male pelvic health or pelvic pain physios, or even women's health physios often treat men as well. You'll find people that might be able to guide you in the right direction. So Carl is he's many things. We tried to describe and define him, and it's a bit difficult from a job role point of view. He comes from a sports massage and therapy background, but he's also a qualified teacher, and he's also an ex pelvic pain sufferer himself. So he innately knows what you're going through, which gives him a really, really good viewpoint, and I think makes him a really better human. He has rehabbed himself and recovered from this, so he knows exactly the journey that you're going on. And also from a therapy point of view, it really gives him a very good viewpoint as to how implementing the evidence-based approach can be difficult, but also how we can do that. So without further ado, I'll bring you the chat with Carl. I don't know if I've already said we were in a hotel lobby. I think I have, but bear with the choppiness of the cuts. It's just that we really wanted to get this chat done, and it's the only time we had together was at Lorimer Mosley's recent weekend conference. So the only place we had to do it was in the hotel lobby, so bear with us. Hopefully you enjoy this and you'll get a lot out of it. I'll put all of the links to things that underneath this blog. If you're looking on YouTube, then make sure you head over to my website where there'll be a full blog about this episode with more links and more information. And without further ado, if you've got pelvic pain or you're suffering, please go see someone. Get in touch with your local GP, your doctor, your consultant, whoever it needs to be. And this can change and you can get better. And those of you treating pelvic pain in men, carry on. Fantastic. Let's chat more. Get in touch with me on Twitter, on Facebook, via my blog. Sign up for the newsletter, which will be down the bottom, where we talk about more of these things more often. And I put up regular vlogs with experts in their field when I come across them regularly. Okay, enjoy. Hello everyone. I am here with the fantastic Carl Monaghan, who is a pelvic pain specialist, sports and massage therapist originally.
Kind of all gets a bit blurred. I had this conversation a few times today. Where are my origins? But yeah, originally sports massage therapist, advanced clinical massage therapy, and then you start doing more research, more training, and your role starts to become a little bit more blurred. I think it's very easy to be defined by our qualifications, but actually who we are as practitioners, who we are as therapists, changes.
Yeah.
And the more we understand about our patients, and the more we understand around pain and the presentations we treat, then again our roles kind of change. I heard a therapist recently describe, so she was originally a chiropractor, describe herself as a coach.
That's nice.
In pain. I thought that kind of summed up very much the line of what I do and what you do as well.
Yeah, I think we work in very similar ways.
Definitely.
From what I've seen and when we've talked over the years. It's Carl, for those of you, you may not be aware of Carl, lots of people are aware of Carl. You really kind of come to the fore in the male pelvic health, pelvic pain sphere. And we've interacted in lots of conferences and courses and come across each other lots of ways with in different forums in that area. So I think it is really hard to define you, because you kind of in the same way that I think my own scope has changed. We're within physio, obviously, because we're CSP registered, we have to be very careful to stay within our scope. But within that, there are areas that grow and change. So certainly, like the coaching side, almost the supportive and emotional understanding, the psychosexual areas of physiotherapy, I've kind of branched out into the last 4 or 5 years, and I think you encompass all of that. So put the label on you is really hard.
It is difficult, isn't it? And I don't like, in the same way I don't like diagnoses, because they can blur the lines, specifically in men's health, men's pelvic pain. If you get pigeonholed as a particular type of therapist, then you're treated like that. And I often get asked, am I a physio? And when I say I'm not, sometimes it can draw blank looks, or, well, how have you gotten into this? How are you working with this patient population? So it's an expanding area. Men do have pelvises. Men do have pelvic floors. I know, it's crazy, isn't it? Dr. Oz, pay attention.
Yeah, exactly. We need more people talking about men. So, being that you just mentioned it, how did you get into it?
Good question. So, in my mid-20s, I had pelvic pain myself. Had a massive infection, lost a testicle, so I had epididymo-orchitis. So the epididymis is a series of tubes that sit around the testicle. That became infected, and the testicle itself also became infected. Grew to the size of about a grapefruit, and then shrunk down to a nub of gristle. So I'm one ball down at the moment. There was a famous song around. Still effective. Have a young boy, have another child on the way as well.
Definitely.
Things are definitely working down there.
Just for everyone that knows that when you lose a testicle, it's okay.
It's okay. And I have nothing to do with the song that was made up around a certain German dictator back in the 40s.
Yeah,
that we won't touch on. So I had personal experience myself. Working at the Prostate Centre, Wimpole Street, about 10 years ago, I realised there was a niche. So I realised there was a hole and a gap in practice for men suffering with these type of symptoms.
Massive hole that's still there.
Completely, and I'm not sure, it's going to take an awful lot to change some of that doctrine, some of that current approach, which is exciting, to be at the beginnings and to help some of these things as well. Definitely, much nicer to be on the wave, surfing the wave as well. That's a nice place to be. They treated prostate cancer exceptionally well. They treated BPH, or the benign swelling of the prostate, exceptionally well. But where I felt there was a gap was when they came to treating patients who had diagnoses of prostatitis or chronic pelvic pain syndrome, as it's also known as. And just the methodology that was used with patients didn't sit well, because I know what they were going through. It didn't sit well with me. And I started to realise that the approach they were using, although gave benefit to some patients, that was good, there was an awful lot of patients that were walking away from there not feeling listened to, ending up in more pain, not being understood, and the patient just got very confused and quite angry and just upset sometimes.
So have you, obviously you're now in practice and you're leading the way for a lot of us, really, kind of in the ways that you've got your pelvic pain kind of support groups that are really trying to bridge that need for men. But what was your treatment like back in your 20s? Good
question. So I had gone into A&E on a Sunday night, and they discharged me, saying it's a twisted testicle, it's nothing to worry about, go back home. And I ended up back in hospital 24 hours later. They were still dismissing me. Was triaged, so was was given a series of tests and assessments from the doctor on call at the time, and they still weren't very convinced that anything other than just a twisted testicle, which is a normal medical normal.
Yeah, not common.
Sure.
Commonish.
Yeah. Presentation. And then they finally realised actually something is not right here. So I stayed in hospital for 4 days, and then beyond that, the care was no care.
Did you get any follow-up whatsoever?
No.
So no one ever kind of rang you and said, go see a physio, go see a urologist?
There was none of that. I had gone back in, the only appointment I had, and I had concerns in my mid-20s, I wasn't in a relationship, but I had concerns over my fertility. You know, I think, understandably. And I went back to see a urologist, and at the time when he said this, I was livid, absolutely furious. He was saying to me, don't worry about your fertility.
Yeah.
All right, it's not something that you need to concern yourself with now.
What he should have been saying is, I hear that you're worried about fertility, do you want me to discuss this further and put your mind at rest?
That's right. And so the language we use, terminology we use as practitioners is essential in terms of bridging that gap with patients, creating that strong therapeutic alliance. I felt dismissed at the time. I see his rationale, and eventually after a little bit of arguing, he did give me a sperm sample pot to take back home.
Great.
I never used it. I kind of came to terms with it and thought, actually, you know what? Yes, I'm livid. I'm not in a relationship at the moment. Am I worrying about something prematurely that I still have plenty of time to recover from and get better? I've got one more testicle. They come in twos. A lot of things in the body come in twos for very good reason.
Got backup.
That's right. Thankfully so.
Yeah.
And beyond that, there was nothing. You know, so I'm now 42 this summer. It's 2019. I was 26 when it happened.
Okay.
So we're talking 16 years ago. Headache in the pelvis, which you may have heard of. Yeah, that's right. It was the Bible. It has been the Bible in male pelvic pain. The first edition of that book came out roughly at the same time when I had my symptoms. The issue is, internet 16 years ago.
Not so good.
I mean, we had dial-up, perhaps.
Yeah. I remember the
smoke
days.
signals,
I know.
whatever it was.
I know.
Yeah.
Someone picking up the phone going, "Get off the internet! I want to use the phone."
And going into a library.
Yeah.
So first of all, I didn't realise there was literature or resources out there. But going into a library as a mid-20-year-old man and saying to the librarian, "Can you help me, please? I'm looking for a book
about testicular pain.
Yeah, I've lost a ball. I need some help because I'm getting a lot of pain in that area."
You're never going to do that.
No. So limited resources, and you know what? In some ways, I think that naivety and the lack of resources on Dr. Google probably facilitated my recovery. I changed my lifestyle. I was aware, as a therapist at the time, I changed my lifestyle, moved back in with mum and dad, gave up my job for 3 months, exceptionally well, didn't have to worry about rent or eating crap food like I was at the boys' flats I was living in, stopped my partying habits and lifestyles, and I got better that way.
Okay.
I think for men at the moment and females with pain, pelvic pain, that if you go online, it can be a frightening domain.
It's terrifying. I always tell everyone and patients that are watching this that when you are at your lowest ebb, where do you go to speak your truth? And the difficulty is that there are very few people that are in our lives that it is appropriate to speak our truth to.
Yeah.
And when you have such an intimate problem, which is often affecting a relationship, it's difficult to speak your truth to your partner or your parents who try to make it better, or other people. So you go online and you tell everyone the intimate details of your life anonymously or with a fake name, and you get rid of all your emotions, and it makes you feel great, but then you put that negative energy into a space that stays there forever. So there's a couple of websites, and I will link to them after this, and I've forgotten the name of them, but there's a couple of patients that have recovered and rehabilitated themselves with a mixture of different things, and I think some of them are physio, but it's not promoting physio, it's promoting recovery.
What a
have
great
a few,
resource.
Sandy Hilton talks about them a lot. I'll put links to them underneath this.
We did a course with her last year in October down in Exeter, and she mentioned a few links around that, because most of the information online, once you recover, and recovery from pelvic pain, male or female, is perfectly possible, absolutely perfectly possible. But once you do recover, you're not going to go back to those support groups, forums, and it's very unlikely that you're going to divulge information or want to engage in that community again, because it can be very, very suffocating.
And incredibly draining.
Yeah.
You know, and if you, going back into that level of fear, panic, pain, tired, fatigue, emotional fatigue from everything it creates can be very draining. Some people just don't engage again because they get better and they get on with their lives and
they get on with their lives and they look to the future. They want to progress, and there are some people out there who do want to help and who do have resources, and I think we'll start to see a few more of these coming through. But you're right. You want to get back. You want to get back on with your life. You want to move further forward, and it becomes. It will always be part of you once you recover from pelvic pain. But it's no longer you. It's not you. It's not your personality anymore. It's not your persona. No. In the same way that a breakup from a relationship, or losing a loved one, that's still part of you, but it's in the past.
Something in the past. Yeah.
It's not what you're currently dealing with.
No, and you can choose to not engage with it anymore.
That's right.
Absolutely. Yeah. So, how has treatment changed then, compared to the kind of the absolute lack of treatment that you got, or any support when you were in your 20s?
Yeah.
Where do you see where we are now?
Good question. So I think in my early 20s, in my 20s, there was the only specialists, practitioners I could have gone to for assistance with would have been neurologists. There were women's health physios, women's health practitioners 20 odd years ago, 15, 20 years ago, but the awareness of male pelvic pain wasn't there, or if it was absolutely minimal. So things have changed. There is still the urological approach and urological treatment, which is good to have.
Yeah, we'll keep going, it's fine.
But I think...
Sorry, apologies, we are in the middle of a hotel in the waiting room.
How nice this is. It's beautiful, it's really stunning. And it's important, so if you are a patient who does have symptoms of pelvic pain, it's important to get your GP and urologist involved as well.
Yeah.
We need to get the specialists on board to run the tests to ensure that there are no medical red flags.
Because, and a lot of the realm that we deal in is very much when pelvic pain persists.
Yeah.
But there are some simple acute disorders like a twisted testicle or infections that are acute, sexually transmitted infections that have not been picked up. There are things that actually can be treated very quickly and simply with drugs, and then there is a large spectrum of things that really can't. But we need to work as a team, so you need to get your GP and your urologist involved as well, and then then that's when they should be referring onwards to people in more therapeutic roles that can help you out.
And there are more options available now. So once you've had the test done, and it is to rule out anything sinister. If anything sinister is there, it definitely needs to be addressed and looked at. More often than not, the patient population I see, all their test results come back negative. So that's a good thing. That also means that there's nothing untoward, there's nothing underlying, that the patient can be confident and reassured. Well, let me rephrase this, or look at this in a little bit more depth. There should be some reassurance and some acceptance of that the test results are clear, and that's a good thing. But when pain persists beyond that, yes, you've been told all your test results are clear, but I've still got my symptoms. What the hell is going on here? Where do I go now? That's where we fit in.
Yeah.
That's where we tend to pick up patients. And if a patient contacts me and they haven't been to see their GP or urologist, I point them in that direction, have that conversation, have the test, I'll have that dialogue with you, I'll be there to support you through that and make recommendations and suggestions as to what tests should be done. But once those tests have been done, that's when there's many more options available to you. And because of that, our understanding of complex pain, persistent, ongoing, long-standing pain, that's pain for longer than 3 to 6 months, depending on which articles you read at the moment. When that happens, pain persisting for longer than 3 months, then it becomes a little bit more complex. It's not just about the tissue. Beautiful, that's
I like
lovely.
Complex and beautiful rather than chronic or...
I hate the word chronic. Yeah. I'm a big wordsmith. I hate the word chronic.
So who was it? There's someone that rebranded pain as complex pelvic pain, not chronic pelvic pain. The name escapes me at the moment.
Yeah.
Someone I've been to see in the last year. I think that's a much more honest way of talking about it, because chronicity has a negative concept to it. And I know pain is awful, but it's also very clever, and it's part of normal homeostasis, so it's how your body regulates itself. It's just that regulation's gone awry.
It tends to go a little bit out of whack. It's not reflective of normal behaviour, normal things that we would expect to see pain from. And I've got a blog on my website around the use of words, and persistent for me is better than chronic. This is my own personal belief. And chronic reminds me of something creaky, like a creaky door shed. It has those connotations. It's as an onomatopoeic word, we're going off track here a little bit, but as an onomatopoeic word, chronic sounds creaky. It sounds like it is stiff and not fluid moving.
Yeah, in English parlance, he's chronic.
Yeah.
It's very negative.
It is, and I think it's also old terminology that we're having to use in a modern environment that doesn't quite fit. And the term prostatitis fits exactly like this as well.
Bugger all to do with the prostate, apart from the location.
That's
really.
right. Yeah.
So how do you? One of the things I really wanted to ask you: how do you explain chronic prostatitis?
Good question.
It's always interesting to know.
Good question. So prostatitis would suggest inflammation or infection. So we have tonsillitis, laryngitis, appendicitis. We can understand those things as being isolated to that gland or that body part. So when a patient is diagnosed with prostatitis, you instantly assume, rightly so, that it's to do with the prostate and there is infection or inflammation within the prostate. Prostatitis. I make quite a bold claim in saying that actually calling pelvic pain prostatitis is a little bit like calling neck pain tonsillitis.
Ooh, I'm going to steal that one. That's a good
That's
one.
yours. I'll give that to you.
Yeah. Oh, that's really good. It makes me think of something because we were at World Congress on Abdominal and Pelvic Pain last week because we are currently in, where is it, May 2019, and Morten, you can say his second name.
Morten Hoegh.
Yeah. One of his statements from his speech last week, his conference talk was, I'm not sure what anatomy has got to do with pain. And I really liked that, and it's a similar thing that, neck pain is not tonsillitis.
No, but the same principle is they're blaming a gland, they're blaming something that might well be contributing, potentially. And so there are bacterial prostatitis cases where there is bacteria within the prostate, but more often than not, the percentage of those are less and less.
Yeah.
And statistics float around, and there's 90% to 98% or thereabouts are deemed as being bacterial. And depending on where you do your research and where you do your reading, will drive that. And there hasn't been any research updated recently to suggest actually that population has changed, that percentage has changed.
Not at all. There's really good evidence from a bladder perspective that I took that question to Washington a couple of years ago to World Congress, that when they talk about irretractable embedded bladder infections, and that the percentage of people with embedded infections, sometimes it can make a difference. We have a very small percentage of cases that respond very well to antibiotics long term, but we as a species live with embedded infections quite well. So if you think about specifically in bladder pain point of view, which is uniquely the same as prostatitis or chronic neck tonsillitis.
Very good.
I know, it's great, isn't it? I'm going to steal that. When you put a catheter in someone, you increase the risk of them having an infection. So in our normal population without pain that are catheterised, and our elderly that are catheterised have chronic embedded infections in their bladder and very little pain or no pain. I know, isn't that good? And when I spoke to some of the really specific researchers into basic science, so when we say basic science, we don't mean a bit basic. We mean the really, really cellular level, really important, interesting stuff. And I talked to them about the problem of embedded infections. They said, well, yeah, that is a thing, but 20% of the population have MRSA in their groins and their nose embedded. That's why you get swabbed before you have surgery, but we haven't got a chronic nose pain problem within our population of 20%. So what is it about prostatitis that makes it hurt? Why does it occur?
Chilling. So there are multiple factors to this, and patients often ask me about the onset of their symptoms. And we look for something, as human beings we like to simplify things, so we'll often use something along the lines of a single thread theory, single string theory, where we attribute the causation, the genesis of something to one single contributing factor. And we blame, even in flare-ups when we have symptoms, we blame one particular thing. Oh, it was definitely that. I can manage that and deal with that. The reality is it's far more complex. And I use an analogy of a perfect storm with patients, when there's enough elements that come together at the right or wrong time, depending on which way you're looking at this, when a patient ends up with pain. I think, and there's no way of testing this, but I believe that when a patient has a range of tests done with their GP or urologist, which is imperative, and everything comes back negative, and they're then told by a specialist that there's nothing going on here, that it's all in your head, or there's no infection, we can't find anything, you'll just have to live with it, or you know what, it will pass by itself, or avoid this or avoid that. I think all of those things are really diminishing for a patient's life moving further forward. Avoid alcohol, avoid caffeine, avoid spicy foods, avoid citrus foods, avoid sex, avoid cycling. That's not an enriched life.
No.
Even if you don't have any symptoms and you're told to start avoiding things, that's not productive.
But it also implies causation. So when you then start to be in a situation where you are avoiding caffeine and alcohol and sex, apart from ejaculating because you've been told to 15 times a day, and riding bikes, sitting down for too long, not leaning over too much in the gym, heavy weights, whatever it is, squats, lifting, everything, and then your pain comes on, immediately you go, oh, I did something wrong. So patients then come to you in clinic and say, so this week I had a chap that said, I did too much in the pool. And I said, okay, what about what you did was too much? And he says, well, I don't know, but it was obviously too much. But he's done the same thing in the pool every week for the last however long we've been working, 9 or 10 weeks. And what was different about that day is that it was a particularly difficult week at work.
Okay.
So actually the system was ramped up, and then he went into maybe a threatening state. But the underlying process in all of this is about how threatened your body is feeling by the potential for whatever's going on, the potential what it perceives to have gone. And none of that means that you're making it up.
Not at all, not at all. But when we can't find an obvious and direct causative factor, then that's sometimes the thing that we're told is that it's not as bad as you think it is. All the tests have come back clear, so there's nothing wrong with you. And that in itself can be quite a damaging message to give to a patient as well. There's nothing wrong with you. So there's nothing wrong with you in terms of your test results, but it doesn't mean that you're not experiencing your pain. Your pain is very, very real. And that is such an important message to behold as well, that your pain is very, very real. It's not in your head. There are multiple factors that contribute to this. And not feeling listened to, not feeling heard, can also ramp up our feeling of isolation. And when we're talking about pelvic pain, it's not the kind of thing you can go around and talk to your mum about. I've got dick pain, I've got pain on ejaculation. When you go to the shops, local shop, and you buy your newspaper or your milk, and someone says to you...
Okay, brief hiatus. But we were talking about how difficult it is to explain that you've got pain downstairs. And often when you've not got calls, when you come back from one of these tests, and there's a when someone comes home, they're often very devastated. There's someone that sat in my clinic this week and cried when I finally, after treating them for a long time, said, where do you think this is coming from? And they cried and said, well, I think I made it. I think I caused this to happen. And that's what often people are left with, or I don't know, it's just happening to me and people won't believe me, there's something wrong. But it's difficult if you're told all of the tests are negative. How do you understand that actually we can have pain in the body without there being a biological cause? Pain is biological, it's real, it's true, but it can be created within your kind of danger centre as a way of saying, hang on a second, I'm a bit under threat, because it's considered itself under threat and it continues and perpetuates in that cycle.
We are organisms, we're very complex organisms, and I know firsthand what phantom ball pain feels like. So there's a lot of research done into phantom limb pain, and also phantom limb pain has given us an awful lot of answers in understanding that we look. So historically, we've been told there has to be something wrong with the body parts in order for us to feel pain. Tissue change, a burn, a break, a fracture, a laceration, etc., in order for us to feel pain. You don't remove someone's arm.
Don't remove someone's arm.
Please don't do that. Disclaimer for the video. But if someone has, amputees experience an awful lot of pain. and phantom limb pain can be one of the reported things that patients feel from amputation. Now I know, and so that changed an awful lot the way we perceive and we understand how pain works itself. Every now and again, and I don't get pelvic pain, no more than I would get an ache in my knee or an ache in my back or an ache in my head, which is just normal, everyday kind of rumblings and grumblings.
Which is really normal. Pain is a normal part of homeostasis.
It's a normal thing.
It's a normal thing. It's a normal part of homeostasis. But there was a but coming.
But it can go awry sometimes.
Yeah.
And so you mentioned earlier on about the guy who was swimming, and he did the same swim routine, but he'd had a busy week at work. Can I use this a second? So I use a glass analogy, and when there are enough things, when the water level rises up enough and we get an overflow of the things in the glass, that's when we like to have an increase in pain or a flare up. Or for non-pelvic pain patients, that might simply be an increase in a health and well-being concern.
Yeah.
I'm going to give a few examples if I can to expand on this. A blueberry's a good food.
Yeah.
A blueberry's a superfood.
Maybe.
They've been termed a superfood in the past.
They have.
I'm not sure. Yeah.
No.
What happens if you have 2 kilograms of blueberries?
Oh, your poo goes purple.
Yeah, gastric overload.
Yeah.
So actually something that's really, really good for us can cause us, in the wrong quantity, really, really distressing situation. Sun. We're told to get sun. We're told to expose ourselves to the sun. Too much sun.
You turn this colour.
Yeah, exactly. Or this colour.
Yeah.
You know, there are lots of things that are good for us that at too high a dosage can actually become detrimental. But when we layer these things up and we start to look at a range of other influencing factors around the pain presentation, your swimming guy, busy week at work, a couple of arguments, maybe not sleeping particularly well, normal swim session, but when we go and we train and we're active, that can put stress on the body itself.
Yeah.
Glass overflows, he has a pain flare up. If I get someone doing this to my testicle that's no longer there, that's quite weird, then it's more often than not because my glass is full. And there are other influencing factors. But at the same time, I might feel generally a bit more fatigued. I might feel a bit more tired. I might feel like I need to get more rest. It's not just about the pain here. So there are other influencing factors. And when you rightly said, when a patient leaves the GP or urologist office and they've been told there's nothing wrong with them, they're isolated. There's often not many people they can turn to and talk genuinely, openly and honestly about what's going on. And that in itself can also perpetuate a state of anxiety or perceived threat, which can also then keep the body on high alert. We become hypervigilant to the area. If there's nothing wrong with this part of the body, then why am I feeling pain? I'll make a diary. I'll journal it, I'll log it, I'll pay attention to every minute change. We become hypervigilant to the area, and we can become a little bit catastrophic sometimes in terms of our thought processes, projecting into the future. How am I going to be able to go to work, on a date, to sport? How am I going to go on a holiday? You know, all of those things. Or we look back retrospectively and think, God, I wish I was back there.
Yeah.
We're not focusing on ourselves anymore. We project into the future and the past.
And all of that really ramps up kind of from a mind point of view. At no point does this mean it's in the mind, but it's of the mind, because everything in our body is of the mind. So on a cellular level, we know that if you have more rumination around pain, so it's really on your mind, it's on your mind the whole time, it's affecting and you're thinking about, well, I can't do this, and I can't go out for dinner, and I can't go and do my run, or I can't do this. That actually we do get changes within the body. We ramp up the threat state. The threat state is real, and we know we get cellular changes at the level of wherever you're experiencing the pain, be it prostatitis, be it bladder pain syndrome, be it penile pain. We know that you can get increased inflammatory markers, we can get increased inflammation, we can get changes in the blood flow, the pelvic floor goes into some degree of spasm with lovely areas of tension myalgia, and we get time for dinner. You know, there are physiological changes that go along with this, and they are of and because of more kind of social or psychological factors, but they're real and true. And so, you know, I'm sure there's a video out there called My Why. So because of my open heart surgery, I'm exactly the same as you, that if I get tired, I get a very achy chest, and everything gets very tight, and I can feel, it's a very strange feeling, although testicular phantom pain is pretty weird and cool, I'm sure. Not horrible, but nonetheless.
It's odd. It's made me question and made me realise an awful lot more around what pain actually is.
Yeah.
Because experiencing something firsthand, a sensitivity that isn't related to a body part, or it's not like you haven't done a heavy swim session to get chest pain.
No.
It's just there's an increased level of what could be called central sensitisation.
Oh, definitely. Central sense, so a brainy pain state based on, in my case, most of the time, lack of sleep. But I become aware, sensate of the whole of the inside of my chest line. I can tell you I become hyper-sensitive. And that isn't because I'm making it, it's because the lack of sleep ramps up the perceived threat, because you're dampened, your system is dampened, so your brain is always trying to keep you alive, aware of the bears. So you become a bit more hyper-vigilant and hyper-aware of the threat, and that means that you ramp up your nerves. Now, the nerves in my chest will tend to be quite heightened anyway, most of the time, because of post-surgery. There was a reason for them to be, and there isn't, and it hasn't been for 10, 12 years. But nonetheless, when I become dampened or threatened in general, or if I'm stressed, then I become very hyper-vigilant and aware of it. But what makes it better? Chilling out, stretching, relaxing, sleeping, eating well, all the things that we know that make things better. And it's not because, balancing, parasympathetic activity, which I go about a lot. I've gone a lot about in these kind of videos with physios, because there are loads of things that you can do, and it isn't. If you're a pelvic pain sufferer listening to this, I don't want you to go away with the thought that we're just going to make you like sleep and eat well.
It may be part of it.
It may be part of it, but you need to look more intrinsically at the drivers that you have, and then holistically at the system. So in male pelvic pain, and I'm interested to see how you approach it. Obviously, we look at the physical drivers. We look at the physical and emotional and social drivers all in one set. 2 sessions generally I do. I'll have a big long chat with someone about stuff before I go anywhere near touching them. Just to see what has been going on, how they're feeling about that, and what else might be impacting on it. Because we're really looking out for, what kind of tension we've got, but also what's going on in life. And then from the point of view of, we may have to pause in a minute, I've lost my train of thought.
So tension is an interesting thing, isn't it? So we often talk of, the other things, the upregulation of hypervigilance and central sensitisation. You mentioned cellular changes, inflammation, nerve sensitivity. But if these things get ramped up and we feel more sensitive, we have these clenching and protective behaviours anywhere in the body. So I give the example, if someone has neck stiffness or neck pain, they're just not going to move that part of the body. They're going to be more protective of it. Maybe their shoulders might come up, maybe their jaw might clench, they might get headaches or neck pain or chest pain or back pain.
So, unfreeze.
Back in the room.
Micro macro changes that you get.
Yeah, so you were discussing things like localized inflammation or sometimes systemic inflammation, increased nerve sensitivity. We may see changes to blood flow, hemodynamics. We get micro changes, but then we can also get macro changes as a result of that. So we might then see clenching or protective behaviours occurring anywhere in the body. Pelvic floor is very, very reactive to stressors or distress.
We know that one of my favourite studies, I'm sure you know this one as well, that when they showed people, not patients, scary videos, scary films, and they looked at different muscles in the body, and the first one to respond and clench was the pelvic floor. So when you are threatened, your tail goes between your legs, because that's what that muscle does in dogs. But in humans, we clench.
We do the same thing. But the interesting thing about that is we intellectually understand a film is not going to harm us. We can rationalise that on an intellectual level, but from a physiological point of view, there is no difference. It's perceived threat. The reason horror films do so well, an awful lot of the recent horror films, is because they work on the psychology of human beings. They get that threat response, they get that stress response. That's why they're so, not for me personally, but why an awful lot of people like them. So micro changes, we can even go down to things like the Krebs cycle we were just talking about now as well. So Krebs cycle, energy production, energy reproduction, recycling of energy. Those micro changes, if we're in a sensitised state and we're not able to recover effectively, then actually our energy production starts to change as well, which then has a knock-on effect onto our fatigue levels. When we get fatigued, we're more likely to be susceptible to things like colds or flus or just other sensitivities. Our immune system gets out of whack. As you can now see, we're complex. Most of the time, muscles get a really bad reputation for the cause of pelvic pain. They're contributing factors, but let's look beyond muscles. Let's take into consideration the nervous system.
Yeah, I would almost disagree, but I know that that's not what you mean. That muscles aren't, they contribute, but they don't contribute because they're a victim as well. We know that we have centralised processes that I go into in depth, and I've done in previous videos, about why you get a tension in your pelvic floor. That was going to be my PhD, and it was answered a couple of years ago. So we know your brain creates this tension state, possibly in a response to other kind of sensory and motor areas in the brain heightening. But we also get this kind of visceral emotional response. But so as therapists or people treating this area, we spend a lot of time kind of lengthening the pelvic floor. But as Laura said, and I'm pretty sure I stole this from her a couple of years ago, you cannot lengthen a muscle without growing sarcomeres. And you can't do that in 30 seconds, but you can improve the resting tone of the muscle by desensitizing it. And that's often the state is because we get those changes in blood flow within the muscle, which when they're tightened, you can't get good blood flow through the muscles, so you get venous pooling, so you get areas of kind of edema, swelling.
Or ischemia as well, which causes sensitivity.
Yeah, absolutely. So you're going to get aching, throbbing, all these kind of generalised pain states within the muscle just because the muscle's in a bad way. If you imagine going into, it's exactly the same kind of as cramping a cuff.
Great analogy, great.
What we do with a cuff, I'm sure we heard Sandy say this last year, it's the last thing you do with a cuff is go, oh, don't touch it. You know, you
leave it alone.
Leave it alone. You stamp on it and you get it to lengthen. So that's what, from a therapy point of view, it's where we see huge gains quite quickly, often, is where we're able to engage in muscle neuromuscular relaxation. What I am trying to define as myofascial release or relaxation of the muscles and the fascial system. I think it's the only term that we've got that really describes the process that we go through, and it's important we all talk about the same thing because then we can search it when we do our research papers. Yep. And I don't have a better term that's all encompassing. Anyway.
At the moment,
there may be more. As things come through, we change it. But also, the desensitisation, you get those heightened processes within the nerves, and the nerves in your muscles become really super sensitised. They're going to fire more often, and we're going to sensitise the nociceptors, and then the information over a period of 3 to 6 months that goes into your brain becomes much more important to the brain from that area, and much more always responsible for a threat. So it may be that your guts are moving around, it may be that you got up quickly and your urine stretched your bladder wall, and you might have had a slight micro contraction because the bladder wall suddenly stretched and it went, oh, I don't want to stretch myself too far, so it micro contracts, and then your brain hears all of that information and goes, whoa, threat to my balls. And then you get testicular pain or penile pain or
normal sensations become very blurred, so patients often don't know when the bowel is full or when the bladder is full, so you might have an increased urgency earlier on because those normal signals of the bladder filling become exaggerated or exacerbated, and the system, not necessarily the person, but the system perceives that as being, well, there's new input, there's new sensation happening here, we don't know what it is, we'll treat it as a threat level, and therefore we can get even more vigilant around things like bladder voiding. You know, and you do an awful lot of bladder work, so our urgency increases, the number of times we feel we need to go into the bladder increases as well. Normal sensations get amplified and increased, so they no longer behave as normal signals from the area. And that can be very confusing for patients.
And it's from a therapist's point of view, it is a really lovely way of knowing. I'm just going to see if we can pause there one minute.
And back in the room.
Back in the room. Okay. So we were talking about therapist point of view. So from a therapist point of view, one of the ways it's really easy to eke out that we may not have correct, true, or more what Lauren calls precise proprioception going on, is whether we do have these interactions between different things. So really simple questions when you're going through your how's my bladder moving, how's your bowel, how often do you open your bowels, does it affect your symptoms? how often do you go to the toilet for your bladder, and we can make judgment calls on whether people have effective movements of those kind of organs, frequency and duration, all that kind of stuff, and deferment, but whether or not it's affecting their symptoms is really important. So it may not be. I've had guys before that, and actually I have lots of people. Actually, I had one last week that came in and he's had some post-finasteride syndrome pain, which is an interesting one, and came in and said, I need a bit of a once over. I need a bit. It's been really sore. I haven't been able to do anything. And we talked to him, and actually, I've been really constipated this week. Okay. And it's that's been kicking things off, and his brain cannot discern between constipation and threat and other things going on. So he's getting a little bit, and the reason for constipation is complex, but
we're also dealing with a highly nerve innervated part of the body as well, aren't we?
Yeah.
So already it's a sensitive bowl, it's a sensitive geographical location within the system. So as soon as things get a little bit heightened, a little bit sensitive, and it's sensitive for a very good reason. It needs to be sensitive for us to be able to enjoy things like sexual function, for us to be able to empty our bowels successfully in an ideal world, or empty our bladder successfully. So we get that feedback.
We've got to be kind of encouraged to do those things.
Yeah.
For the fulfilment of the species.
That's right. Yeah. Although we wouldn't be here doing this podcast either.
No, exactly. It's feeling great.
Yeah.
But it is important that we have good sensation of those areas, and that's why they're heightened. But they're also incredibly emotional. So we have, we have pelvic pain specifically, and actually to some degree, pelvic pain, I would say, out of the whole of the body, is probably one of the areas most sensitive and where it's the most easy to have that perfect storm. Because all of those things about fatigue and diet and stress and lifestyle and all those kind of things will affect everywhere. But they affect the areas that are the most emotionally sensitive to us and physically sensitive to us the greatest, and the ones we can't see. Also, like backs as well.
Yeah, exactly. Well, with backs as well, you can say to someone, okay, you're sensitive, why don't we reduce what you're lifting or avoid, I don't never say avoid lifting for now, but perhaps let's consider how to change that. Yeah. You can't say to someone, right, well, don't pee for a couple of days and we'll see how that works out for you. Yeah. Or don't have a bowel movement for a week and then we'll kind of revisit things. This is normal function that we cannot stop, because actually if we do stop them, then that has much, much greater knock-on effects to our health and well-being as an organism as well.
So, going back to my question originally, when you were talking about explaining to patients, I think it's a silly question because I think I know the answer to it, but how do you approach starting treatment with people? Good
question. And so, there are a number of reasons I do these, but I have a huge amount of contact with my patients from the initial email inquiry or telephone inquiry they send through. I send a long, so the number of forms I get my patients to complete before I see them is a medical intake form. We then look at GAD-7 forms, PCS forms. So this is general anxiety disorder, pain catastrophization, pain self-efficacy. I include in there the National Institute of Health, CPSI, the Chronic Prostatitis Score Index. So it gives me a range of data to track and see a patient's progress, but also it's relevant to the individual. From there I arrange an initial Skype consultation, which takes about 30 minutes. This is to go through in fine detail the intake forms, to build up an even bigger rapport with the patient. At that point I start to get them to, between the end of the Skype and the face-to-face session, I get them to start thinking about goals. So I ask them, I'd like you to identify 3 things you'd like to be doing more of and 3 things you'd like to be doing less of. And it gets them thinking when they've recovered. And then we start working towards them in the face-to-face session. So already they're looking beyond where they are, and they're looking at things that really influence their own individual, because it is individual. Although there might be some similar symptoms from patient to patient, the individual goes through their case by themselves quite often, because it can be so isolating. So these meaningful activities to do more of or less of then set the precedent for where I take the face-to-face session. So before I even see a patient, we've spent a lot of time with them, going through understanding, creating that therapeutic alliance, building up trust. And normally a patient may have had 5, 10, 15 minutes with a GP or urologist up to that point, or they've gone in and been dismissed off pretty quickly. The face-to-face session, the initial one, is 100 minutes, and that's where I do up to 100 minutes. Sometimes it goes beyond that, but we sit down, I go through the case again, and I say, okay, where do you want to take this? What are your objectives? What do you want from the session? I have my bias, I have my agenda, but this is your time, so let's use it wisely. And I always include, through metaphor, through storytelling, things like the water glass analogy or the bear. You mentioned the bear. So we can poke the bear. Thank you, Greg. This is yours. We can poke the bear, Greg Lehman, but we can't hunt the shit out of it. It's okay to push and to adapt the system, but don't piss it off.
Yeah.
It's these principles and practices that allow a patient, through fun, metaphor and storytelling, we deliver really serious science and medical information in a nice packaged format.
Yeah.
Then do a range of assessments, physical, movement, and then start setting up a self-care program for a patient that's individualised to them, which will include their meaningful activities as well.
This is one of the things that often I get emails back, and I'm sure you get emails as well from people saying, I've got this patient, tell me how to treat them. And you just kind of, it's one of the things that I do in my teaching, give out some guidance. So there is a good amount of research that says 6 weeks of myofascial release, any kind of pelvic floor active work, should reduce symptoms, and my data reflects the international kind of the big 6-7 trials we've got now, of about 50% reduction in symptoms, bladder urgency and pain when you're touching the pelvic floor, which I think is really interesting and cool, that you can touch the pelvic floor, go nowhere near the bladder, do no bladder interventions and change visceral pain in 6 weeks. And I don't say that to say, right, you have to do 6 weeks of this treatment. This is a guide for the kind of improvement that you should see, but also about increasing your kind of giving people a little bit more power to their elbow, so that you don't feel that when you're seeing patients for 5 weeks and you're kind of like, oh, where are we getting to? That you are continuously doing it, because the point of view is repetition. You're teaching the system, I am safe. Because you've done all of that stuff, you've built that therapeutic alliance, you've given them a desensitised approach just because you are trying to help them, you're listening to them, you're in there with them, it's a collaboration, and then you're doing something with them, to them, but with their full understanding, so that's desensitising and just ramping it down. I've just got Greg's comments in my head now, you know what I was about to say. Yeah, it's swearing anyway. So you're just bringing it down, and actually that ramping down of the system we know needs to happen for about 6 weeks. So I did work into the wand. There's lots of work in using manual devices. We know it doesn't have to be a therapist, it can be the patient themselves. Very happily, there isn't actually data to show how effective it is versus therapy, and I'd suggest a little bit. I did a little bit of it, but there's not very much at all. But I'd suggest the therapeutic alliance and seeing someone is partly, and having someone give you information back to you is part of the empowerment. I don't think that the therapist lengthening the muscle, finding the trigger points and getting rid of them, sticking them until they're gone, is actually what creates the difference. It's about really ramping down the nervous system and creating safety and a safe space, and then giving them that experience of safety, and then giving them the ability to create that safety in themselves.
Totally, and this is the reason why I spend so much time in giving patients an understanding as to the contributing factors, because they then feel a bit more safe.
Yeah.
They then create trust in themselves again. They then start to believe that actually, although the test results have come back clear, maybe there isn't anything really sinister going on. Maybe it is around sensitivity.
Yeah.
If we really, really break it down, that there's not a tear or a break or anything along those lines. That it is more about tissue sensitivity in a very sensitised part of the body.
Yeah.
Self-efficacy for me, teaching patients their own self-care is huge, because they then start to.
It's the best thing you can do. All of the evidence shows the minute that we take the impetus off us to heal as healers, and we say, how are you doing with that, or how are you thinking of moving forward, and we give people the power to change their own lives, that's when things improve. Much, all across the board, from carpal tunnel syndrome to chronic tonsillitis to whatever else that we have. If you've got self-efficacy, you're going to move people forward faster.
Totally. And when a patient only feels they make progress in your clinical office for 1 hour per week, that's an awful lot of pressure to place So it takes away, it's disempowering for the patient and places emphasis on the therapist as the key element to get them out of their pain presentation. That's not, for me, empowering for the individual. I like to make the patient the driver in their recovery, not just the passenger. I want them to be at the driving seat. I want them to steer the car. I'll guide them. I'm almost like a sat-nav is what I tell my patients.
Yeah.
We'll point you in the right direction. Every now and again we may need to do a U-turn and come back to things.
Yeah.
That's recovery, and that means we're then offering bespoke and individualised care for that particular individual based on their case and their set of symptoms and their history and their lifestyle and everything else that comes along with that individual.
So next time either of us get that email, I'm just going to send a link to this.
Watch this video.
Watch this video, because it is, we're the holders of a great deal of knowledge of what can be available from PTNS, posterior tibial nerve stimulation, be it acupuncture based, be it electrostim, be it TENS machines, which I like. I use TENS a lot because they're not offensive and they tingle away nicely, and they're something you can simply put on and have around the house as a different stimulus, to binaural beats, so using different sounds and trying to repeat motions, to lots of different stuff, graded motor imagery, thinking. We have
so many tools available to us, isn't there?
Yeah, so many different things that you can do. And I will say to patients often, and they say, I've been through physio. I get a lot of abuse on YouTube. I'm afraid I've stopped interacting, so you won't find me in the comments. Just because I get a lot of abuse of people that have been to see someone that have been acupunctured and they get better, and so they come back for their acupuncture and they get better. But they haven't actually been led towards developing their own strategies and moving forward. And acupuncture's fine. From my point of view, I think it opens up your parasympathetic activity. We get a massive parasympathetic response.
Yeah.
You get a bit of descending inhibition. It makes you feel better. It's a way into opening up the system to have that experience, but it shouldn't be relied upon to. And I'm telling myself this because we've all got those patients that are relying on acupuncture, and we need to move them forward onto more kind of self-efficacious routes of health.
Passive therapy is absolutely fine. I have no issues with passive therapies. If someone doesn't like needles, suggesting to them they should go and get acupuncture as to help to calm down the sympathetic nervous system is probably not the right thing to do.
No.
So maybe
massage would do the same.
Maybe massage, maybe reflexology.
It's just I'm lazy. So
yeah, that's right.
I don't want to massage every day.
This is hard work.
While talking to them, but they, even massages are amazing opportunities. If someone's really ramped up, get them lying on their face if they're feeling safe, and gently touch their back or their pelvis or their arms or whatever, and you will see them have that parasympathetic response to chi, as we call it in acupuncture, and you'll see them calm down and they'll feel great when they sit up, and you'll have talked to them about all of the things that you wanted to talk about.
Captive audience then, don't you? You have the ability then to impart that knowledge around a bit of pain science that's wrapped up in a very palatable, digestible fashion as well.
I'm giving you the tricks of the trade now, so if anyone comes in and I end up
sticking their face down,
just because I want them to listen. Oh, no, maybe not.
But I think also that this is important. I think as therapists we have a duty of care to our patients to be able to give them that information as well.
Yeah.
Because our words can be incredibly detrimental.
Nocebo language, we talked about it today as well, that the amount of negative language, so I get at least 8 emails a week, it's more than one a day, saying my therapist has found trigger points in my pelvic floor, please can you tell me how to use the wand to get rid of them. And if you give someone something, it's a monkey, they carry their monkey.
I like that.
Amanda Savage. Amanda Balatti. She spent her life telling me to give back the monkey because I've taken on something else to do. But everyone now, if you have a feel of your shoulders, I've been sat down all day. Oh, there's a nice big area there that's sore. There's a big area. Oh, that's a really nice sore.
But there must be, if there's pain there on palpation, there must be something wrong with your shoulder.
There is nothing wrong with my shoulder.
Can I? Yeah, give me your hand a second. What about this bit in here?
Oh, which is a bit further back, and it'll be really painful. Oh.
It throws across. So there must be something wrong with that hand.
There's nothing wrong with this hand.
Are you sure? But it's painful.
This hand is fine. The muscles are a little bit tight and sore, and that's because I haven't moved today.
Yeah, we've been sat at Laura Mosley's conference on pain, not explain pain, not noise. It's Laura Mosley's gig, so there's been a lot of assimilation of information, or sitting down and trying to take on board what's happened. So I'm stiff, I'm achy, I need to get up and move. Yeah, perfectly. Our systems have been at rest.
Yeah, and that kind of, so the minute that we tell people you have muscle tension, therefore that is causing your pain, that's a really poor concept. It reduces their pain to just being a physical entity, as opposed to now that's aching.
There must be something wrong with your hand.
There must be something wrong with my hand. As opposed to for whatever reason, for what. So classically, right? When I did research, when I do a lot of writing for journals and stuff, I was sitting like this for a long period of time. So you get tight, you get fixed into that position, and so you might get achy. And the achy is not necessarily because my muscles are tight and they're causing the aching. The muscles are tighter because I haven't moved and I've been in a fixed posture for a long period of time, so they've had to sustain a contraction to keep me in that posture. And that sustained contraction for a long period of time, it's a bit like post-postural contraction. If you put your arms out, if you stand in a doorway and go like this really hard for a while and then step forward, your arms float up because your muscles continue to contract. So if you're in a sustained contracted position, I don't mean contracted, just even in this position, I'm being held.
For any length of time.
For any length of time, your muscles are going to keep doing that. They're working hard, so you need to get up and move. We're built to move.
But also your body, by giving you the experience of aching muscles, it's communicating with you saying,
move.
We need to move. Yeah. I go through a range of different things like this with my patients. So if we've had too much sun, we get sensitive to the sun, we get sunburn. If we've had too much, so if we inhale something that's not good for our systems or it's sensitizing, we sneeze. It's our body's way of reminding us that actually that's probably not a good thing, maybe move away from there. If we vomit something back up, that's our body's way of telling us, probably don't have that again. Yeah. Our bodies talk to us all the time, but quite often we don't listen to them, or we don't understand, and I'm not saying I'm an expert at this by any stretch of the imagination, we don't understand, and we see pain as being a bad thing. Pain is necessary.
Not a bad thing.
No.
Pain is really useful. You would not want to live without pain. It's that lady that recently has been diagnosed as not having nociception or not having the ability to have pain or create pain in her body. It's a really dangerous life.
There's a population up in Sweden, I think, that are being investigated. And patients who don't experience pain ever, they often don't live past 30 years old.
Yeah, they cut things off, they get gangrenous, they get infections. It's a really bad thing. Pain is very useful.
Can be incredibly informative, providing we're able to understand it and work with someone who can teach us how to.
Yeah, but when we're in a position where actually our nociception, our pain has become the primary thing that our system is concerned with, because we are not homeostatically regulating the rest of us for whatever reason, we're completely out of kilter, and we're fighting bears all the time, then we need to get out of that system. And sometimes it takes a bit of time and a bit of thought and a bit of input, but the more different inputs that you can put into that constant chronic cycle, the more that you can come out of it. And we're both, I don't talk about myself very often, but I had 8 years of chronic pain, lots of different places, and I'm now pain free. I know.
High five. Same. I had a horrific experience of my pelvic pain, and I now don't get the flare-ups. I don't have that ongoing gnawing, deep, aching pain around my testicle or my perineum or around urination. It's a thing of the past. Yeah, it's a thing of the past.
And that can be normal, and I think yes, it's probably easier for us to sit here and say that because we're both health professionals, so we're highly educated in this area. And that probably has changed our neurotags of thoughts and beliefs that will affect how long-lasting that cycle of perpetual pain was. But I'm sure when we were in it wasn't easy to dig yourself out of it.
God no, you kind of almost feel like you're in quicksand or sinking sand. It's very difficult to get hold of a grasp of anything, and when you do get hold of a grasp of something, you don't want to let go of that. You want to hold on to that for dear life.
And then the next week it's bad again.
Yeah, and you're like, how is this happening?
Yeah, but I think from a physio point of view, very quickly I became very comfortable with it. Okay, well this week I'm in pain, next week it'll be better.
Yeah.
And let me design my life around what keeps me better. So I did 7 hours of Pilates teaching a week and lots of hydrotherapy, and I run and I do triathlons. But now managing my pain is much more about managing energy and managing emotional. So am I doing enough mindfulness? Am I seeing my family? That kind of balancing yourself.
Balancing the scales.
So What 3 things would you say to professionals? What pieces of wisdom would you share with professionals managing or trying to get into treating or managing male pelvic pain?
I would encourage practitioners who do see male pelvic pain patients to consider the elements of the biology, the psychology and the sociology. We've talked today about how they shouldn't be separated, how they should be one entity together, the biology, the psychology, the sociology. But when we look at the biology, and this might be sensitivity, it might be holding patterns, it might be the way a person moves, or clenching behaviour, that can give us a clue. But don't stop there. Look beyond that. Look at how that then has a knock-on effect onto their psychology, their thought processes, their beliefs, their faith systems, how that influences their confidence and their own self-efficacy. And then look at interactions, relationships, socialising, how that has a knock-on effect onto work, how they stop going to their club to go and play tennis, and that removes a whole element of who they are. So actually the 3 things I'd suggest that people look at, the biology, psychology and sociology.
Perfect.
Listen to a patient.
Who is it that says listen to your patients and they will teach you how to treat them?
They have all the clues and the answers themselves.
They have all the answers. From a social point of view, we can't, what's it called? There's a word I'm looking for, diminish. There you go. We can't diminish pain to being just their social circumstances. And we all know there are certain sections of patients who are, you can see very easily from the outset that actually their socioeconomic situation, their difficulty at home, social drivers for their pain are great. Doesn't mean you dismiss them. No. The amount of patients that I've seen who their isolation is a massive factor in their pain. When I used to work in the NHS and slightly kind of poorer areas, that wouldn't get out to the pub, the loss of, I live and work in South Wales and the mining communities, when the pubs started closing and the mining communities are up big hills and you've got some pain, then it's difficult if you've got to go further to the pub, and then if you stop seeing your friends so often, and then it just spirals and actually pain increases, and it is a legitimate cause of pain. It doesn't mean, it's in their head. No, we know that those neurotags work together and we end up hypersensitizing the system. A social interaction, it ramps down some of those threat states and inflammatory drivers and sensitivities. So they are equally as powerful, and we need to be looking at those. Okay, so what 3 things would you say to men with pelvic pain?
So the very first thing has to be, if you haven't done this already, go and get yourself tested. Go to the GP, go to the urologist, go to the gun clinic, rule things out. Make sure there are no medical red flags that may be influencing your pain state. That has to be the foundation before anyone else can move further forward with recovery.
Yeah.
Secondly, know that there is help out there. You're not alone. There are resources now. There are physios and therapists across the UK and across the world indeed that are now offering resources, treatment, support, guidance for patients like yourself or people that you know that have symptoms of pelvic pain. So you're not alone. And work in collaboration with your therapist. This has to be essential as well. You, as an individual, you, the patient, you know your body far better than any expert can ever claim to know your body. You hold the answers to how to get you out of your pain state. But unless you have a strong collaboration, a strong therapeutic alliance with a compassionate therapist who will spend the time to go through things and to help you get out of your current situation, then you're missing a whole part of recovery, the whole potential of recovery as well.
That's brilliant. I absolutely agree.
Good. That makes my life a lot easier.
Yeah.
Thank you.
I think most people would.
Yeah.
That collaboration is really important. I think a lot of people feel really disempowered when they go to see a health professional.
Yeah.
Because they say, oh, he says I've got this, so I need that. And I get a lot of patients that say we use cystoscopy as an example. So when people put a camera into the bladder, and a lot of patients will come to me and say, right, they want me to have a cystoscopy. If it's the first time round, that's standard, that's a normal part of NICE guidance. All patients, like Carl was saying, need to have a cystoscopy before they end up with me from a bladder pain point of view as part of the investigations. But if it's kind of their 3rd or 4th one, and we get to a point where we go, well, why are they doing it? most of the time, to be honest, my consultants, I'm able to have that chat with them and say, what's your reason? And if you're suspecting something or you're suspecting you'll get some useful information, great. But things like that will actually be quite detrimental because it might flare symptoms up. It's going to put you back in a horrendous position for a couple of days. And actually the patients need to be a bit more empowered to kind of go, why am I having it? What benefit is there going to be to me having this treatment? What are the negatives? And really having an open conversation, like you were saying with we were saying you should have had with your doctor, who should have said, I can see that you're worried or you're nervous about your fertility, let's have a conversation about that, instead of saying, don't worry about it.
I can see that this is what you're going through. It's acknowledging the patient and their current situation, and then it's a case of, right, I've become aware of this, I'm making you aware that I'm aware of this. Now what do we do about this? You start to create an alliance, a working relationship towards recovery.
So
powerful.
Working together. Dream team. But it's a good phrase, and again, who have we stolen that off? You'll find the more videos that we do with more people, I'm finding that you are a product of the learning that you do.
The people that are around.
So the wider the breadth of learning that you can have, the better. But that thing about the patient is the expert in themselves. I always say to people, you are the best expert in you, let no one tell you otherwise, because you're in your body and I'm not.
And you have to deal with it every single day. You know the nuances, you know what it's like to get up in the morning, or to brush your teeth, or to go and empty the bladder, or to have sex, or to go to try and go and have a social life with someone. Whether that's with your partner or friends or family, you know what that feels like wholeheartedly.
So, and we want to, and we don't, so you need to tell us. And that's the last thing I would add, is don't be embarrassed. You can see there are male therapists that you can come and work with, and actually Carl's on one of my standard emails that I bounce back to my patients. I always give men an option, because looking at downstairs is like looking at elbows to me. I've seen so many. We're medical professionals, so it's boring, and we will ask you lots of in-depth questions, but you're probably the fourth or fifth person at least that morning that we've asked these questions about, and we're asking them for very specific reasons. We take due care and attention, and we know that they're very difficult for you to answer, but from our point of view, we're interested in the answers, but we're not taking any kind of
it's data, isn't it? It's black and white information.
It's information for us. So when I'm asking about someone's sex life, I generally, if there's a pause, I say, look, I'm really not interested in your sex life, I'm interested in how your pudendal nerves and the anterior clitoral nerves are working. And they go, oh, okay.
And you might want to try and find, with sex, it might be simply a case of, right, I'm not interested in your sex life, but if we can find a position that's more comfortable for you, then that's a working model moving further forward, isn't it?
I'm only interested in your sex life as far as goes if you want to be having it and you're not. Then we're going to try and help you to have that together, but we're obviously not going to be involved.
No, we won't be there coaching you
on the sidelines. Try rolling onto your other side. Is that better? That's horrendous. I can't imagine doing that. But just don't be embarrassed. So when patients, I don't think a lot of men go and seek help. And certainly we're not out there. We are out and proud about services that we provide, but when they do seek help, it takes a lot of effort
and courage.
Massive amounts of courage. You have to be incredibly brave to even turn up, and we know that. Everything, when you go to a clinic, and certainly our clinic's running the same way, we will send you questionnaires before you get to us. When you get to our spaces, pelvic health clinics tend to be run incredibly privately. So I have a space which has other people in the clinic and office around me, but it's very private. There tends to be one patient in the waiting room at a time. It's really comfortable, you can have a cup of tea. The rooms are completely closed, private, you won't get anyone else in there, so you can speak your truths quietly. But also know that there are lots of women's health physios, so females that will treat male problems, and if you're okay with that, great. And I get all the men that I see are great with that. And if you don't want to see a woman, that's also fine. So in my standard form now, I have two. I have a local guy who treats male pelvic pain, and I see a lot of patients that come over from London or do other stuff, and I will send them to Carl, because you have options.
And that's also empowering to know as well that you're not going through this by yourself. There are other people out there. And it's important to talk. Bob Hoskins said a while back, a couple of decades ago now, but it's good to talk. I think the more we're able to talk about this, the more honest and open we are about our pelvic pain, men and female. I'm going to send this particularly to you chaps as well, but it's really, really common, like more common than we're let on to believe. And the prevalence and incidence reports that we have in studies, I don't think tells the whole picture.
No, people don't report it.
No.
You know, we know we're vastly out on female issues and female pain, and that is a little bit more socially appropriate. I think men will silently put up with pain.
It's normally 2 years, I think it is, before a man will go to the doctor and report there's some, not necessarily pelvic pain related, but report a health concern or a health issue. Maybe in that time he has or he hasn't spoken with friends or family. That's an awful long time to be suffering in silence. An awful long time to be suffering in silence. So let's get talking. Let's be open and honest with ourselves. Let's engage as a species, as a gender as well. Let's engage. Let's not go down the pub and just joke about our dicks. Let's actually start talking about them proactively. That's a really important message.
Yeah, as an important part of your body.
Yeah.
So I know that you've got a support group.
Mm-hmm.
Do you want to talk about that?
Yes, thank you very much. So I run an online support group for men suffering with pelvic pain. We have anything from little chat rooms within the support group itself. They're offered via Zoom. I will have guest speakers. We had Henri Astier, who's a BBC journalist who wrote an article about how he recovered from pelvic pain. He gave a presentation. I've got a clinical psychologist who's just going through and doing her PhD. Sally, hi Sally, if you're listening to this or watching it, she's just about to do some research into men with pelvic pain, and she will be part of one of the next support groups we have. There will be either patients who've recovered or experts or specialists to run some of the dialogue and some of the conversation on these as well.
So it's a really safe space.
Yes.
And an informative space. And how do people find this space?
Yeah, so my website is a great place to find it. www.thepelvicpainclinic.co.uk. There's treatments on there, there's resources, there's lots of articles based on contemporaneous research, up-to-date research, and there's information on there about the support groups as well.
Perfect. So I'm going to call to a close now because we've had quite a good chat there. We're both getting hungry. Yeah. Time for another pint. So thank you for listening if you've listened so far. Please spread the word, share this message, share the video wide so that we can really start gaining some momentum around the conversation around men's health. It isn't just about prostate cancer. We've broken that taboo.
That's great.
You know, the
10 years ago.
taboo is gone, but
fantastic.
now we need to start talking about that men get pain too, and that it's okay to talk about it, and it's something that we can treat. Underneath at the bottom here somewhere there will be a newsletter sign up, so if you're interested in hearing more about these talks that I do, sign up for the newsletter and you'll just get something in your inbox. I'm not that great with them, so don't worry about getting loads of spam. They'll be every now and then when new things come out, and I think that's all. Any other resources that I've mentioned will be underneath this. I'll try and put as many as I can find. There's some good couple of websites and things coming up. So thank you very much, Carl. It's been an absolute pleasure. It always it gives me such joy when experts in the field share, because as I always say, it's how we all build and gain knowledge, is when we're open and honest with each other and share our practice. And I'm sure this will not be the last chat that we have, because I've already got more things that I want to talk to you about.
Yeah, good.
So thank you for coming on today.
Pleasure. Thank you very much for having me. Thanks for joining us.
And we'll see you again soon.
Take care. Bye-bye.